My name's Simon Kenny and I'm the National Clinical Director for Children and Young People and also the GIRFT lead for children's surgery. And thanks for your interest in the abdominal pain and appendicectomy pathway. Every year, thousands of children develop abdominal pain, and sitting amongst them all are some children who've got more serious disease such as appendicitis. And when we look at those approximately 9,000 children who develop appendicitis each year, too many of them end up having a normal appendix removed and unnecessary surgery. Or perhaps more importantly, they end up having their early signs of appendicitis missed and then present later with complications or with perforation. So this pathway will take you through the early processes of identification and assessment of children with abdominal pain, through to what investigations to do, and then if appendicitis is confirmed, the steps through operation right through to discharge. We hope you'll find that this is useful, and it's supported by audit tools which will help you to look at your own progress. So many thanks for spending the time to look at the appendicitis pathway, and I think we all look forward to seeing the improvement of care for children with abdominal pain in this country. Thank you very much.
My name is Simon Cortman. I'm a consultant paediatric anaesthetist at University Hospital Plymouth.
My name's Caroline Morrison. I'm the paediatric clinical nurse specialist at University Hospitals Plymouth.
A few years ago in the Southwest, we did a region-wide audit of children presenting with suspected appendicitis. And this highlighted to us that we were underestimating the pain that children were in, not only at presentation, but throughout their pathway. And it drove us to change our practices and introduce several steps to improve the management of pain in children with suspected appendicitis. The first step of this was the introduction of a trust-wide pain assessment tool for all staff to be trained in and be familiar with. And I think Caroline's just going to tell us a little bit about that.
So as previously mentioned, all nurses are trained, including our nursing students and HCAs, on how to assess a child's pain. They are expected to record it on the observations chart and record their pain scores with every set of observations that are taken, and this is regularly audited throughout the year. We use self-reporting pain scores where possible. We try a FACES tool or a verbal numerical rating score of 0 to 10. If the child can't report their pain, if they're under the age of 4 or unable to communicate verbally with us, then we'll use a FLAC, FACES leg activity cry and consolability rating score. Depending on the score, we'll then use the WHO ladder to determine the analgesia that is given. And we start off by simple paracetamol, ibuprofen, regularly given throughout the child's stay. We'll then add Oromorph if required. If the child can't take oral analgesia, then we'll look at IV paracetamol with IV morphine.
Thank you, Caroline. And I think it's just worth remembering that, we also include intravenous non-steroidals or oral non-steroidals where appropriate. And obviously, some children with severe sepsis, you just have to consider this before prescribing. Some children will present with severe pain from their pain scores, and so will require opiates. And for some of those, oral opiates will not be satisfactory. So there has to be a protocol in place for administration of intravenous opiates, both as boluses to take control of the pain on admission and for PCAs and NCAs later in the pathway. So for children who then progress from being admitted to requiring surgery, in that post-operative phase, particularly where we have found significant appendicitis with signs of infection, and evidence of peritonitis, we would prefer, following our audit, to introduce the prescription of PCAs or NCAs for that group of children. We have found that since doing that and re-auditing, that our pain management has dramatically improved, and that children, although only requiring it for a short window, have a much improved experience and pain management. Following a period of stay on the ward, preparing for discharge and pain management at home is another part of the pathway that has to be discussed and considered.
So we explain to all the children and their families that some level of pain is to be expected after surgery. Just because you've had your appendix removed doesn't mean the pain is going to go away. We then suggest that regular analgesia is given at home, and to make this easy for the parents, we suggest that they take it at breakfast, lunchtime, tea time and bedtime. If they're worried about overnight analgesia, then we say give one of the paracetamol or ibuprofen at bedtime and then keep the other behind so you can give it during the night. This tends to work for all our families, though some will change it so they can do staggered doses, but that is their choice. We very rarely give Oromorph for discharge, but we can do, and we will give a maximum of 3 to 5 days. They are not allowed it any more than 6 hourly, but most of the time when we follow this up, it may be one dose given the first couple of days after discharge.
So in summary, the key messages for optimal pain management of children with suspected appendicitis is regular standardized pain assessment by all teams, leading to appropriate prescription of analgesia and delivery of analgesia regularly, with rescue analgesia such as opiates being prescribed when required, and then clear instructions to continue analgesia on returning home. Thank you very much.
Thank you.
We will be covering the implementation of a documented structured clinical assessment of a child with abdominal pain, looking at a child with suspected appendicitis, performing screening blood tests to guide decision-making, perform a clinical risk score for children when indicated. My name is Professor Ian McConaughey. I'm Professor of Paediatric Emergency Medicine at Imperial College, and my colleague Dr. Thomas Shortland is a clinical fellow in Paediatric Emergency Medicine. We'll be talking about the pathway components titled Adoption of a Diagnostic Pathway for Children with Suspected Appendicitis as part of the Paediatric Acute Abdominal Pain and Appendicectomy Best Practice Guidance. We will discuss why it is a key area for quality improvement and why it is important. We will highlight the challenges you and your team might encounter when implementing it, and how your units may be able to overcome the problems. We will go through the tools, guidelines, and the frameworks available to be able to deliver this guidance in practice. We'll also be touching on auditing.
Acute abdominal pain is a common concern among children, and it's important to manage it appropriately to ensure the best possible outcomes for those affected. The guidance from Getting It Right First Time provides practical recommendations for managing acute abdominal pain and appendectomy in children. Implementing the advice from this guidance will help reduce unwarranted variation in the quality of care. It will also enhance the coordination between professionals involved in the delivery of that care and improve outcomes, such as lower rates of negative appendectomy, fewer presentations prior to diagnosis, shorter hospital stays, and reduced readmission rates. Healthcare professionals may encounter several challenges when assessing children with acute abdominal pain. These include differentiating between benign and serious causes, assessing the urgency and the severity of the acute abdominal pain, and implementing the appropriate management. Here we have the flowchart for the acute paediatric pain and appendectomy pathway for suspected appendicitis. If a child presents to hospital with abdominal pain, then a structured assessment of their abdominal pain is needed. Analgesia must be given promptly and will not impair the assessment of the child. Do not withhold stronger analgesics, such as opiates, if these are required. If acute appendicitis is suspected, then an FBC and a CRP should be collected as screening bloods, and if raised, a clinical risk score should be used. Depending on whether the risk of appendicitis is low, intermediate, or high, the other branches of the flowchart should be followed and appropriate management initiated. For high risk of clinical appendicitis, start IV fluids, ensure appropriate analgesia, and give IV antibiotics within 1 hour. For intermediate risk or high risk with alternate serious diagnosis possible or appendix mass, arrange an ultrasound scan, Be aware that ultrasound scans are not 100% sensitive. If appendicitis is not suspected, then the non-appendix abdominal pathway should be followed. If required, further imaging and/or blood tests can be utilized. If surgical disease is indicated, then clinical management should include IV fluids, analgesia, and IV antibiotics. If there is no indication of surgical cause, non-surgical causes or discharge should be considered. Regular auditing of the care provided to children with acute abdominal pain is important to ensure that best practice is being followed and to identify areas for improvement. The Getting It Right First Time team is currently developing an audit tool to help departments monitor their own performance against the guidance provided.
In conclusion, managing abdominal pain in children requires a multifaceted approach that includes the use of tools, guidelines, and frameworks to overcome common challenges. By following the guidance provided by Getting It Right First Time, healthcare providers can improve the quality of care for children with abdominal pain and improve their outcomes. We hope this video was useful. Thank you.
So hi, my name's Erica Macon. I'm a consultant paediatric surgeon at King's College Hospital, and I'm going to be talking today about the acute abdominal pain and appendicectomy pathway. This is part of the educational webinar series. The aims and objectives of this talk are to provide some baseline structure with respect to assessing and referring on patients with abdominal pain. It's very important for patients to have rapid access to appropriate services, appropriate treatment, and adequate referral on to the secondary care services. I will discuss why it is a key area for quality improvement and why it is important. I will also highlight the challenges that the primary care services may face with assessing and managing these acutely sick children. I will also go through some tools that might be helpful for you to triage and assess these patients and institute initial management and secondary referral onwards. There will also be consideration of opportunities for auditing tools. So why is it a key area for quality improvement, and why is it important that we follow the recommendations that have been set out? Rapid access to appropriate services for children with severe abdominal pain is vital. And typically, non-specialist hospitals should offer appendicectomy for children over the age of 5 years. Specialist centres will provide the specialist surgical care for appendicitis under the age of 5. Your lifetime risk as a male for developing appendicitis is approximately 9%, and for a female, it's 7%. Children who present with appendicitis under the age of 5 can present very atypically with a prolonged history. So it is quite important that we have some tools at our disposal to help us with the diagnosis and initial appropriate management to prevent delay in ultimate treatment. In order for this to be assessed and for smooth transfer of patients, the receiving secondary care team must have a referral system in place which does not create long delays for the patient or the primary care physicians who are referring the patient. Rapid access to an appropriate service is important so that the child can be appropriately assessed, interventions can be put into place in a speedily fashion, and so that these services can respond to the children's and the family's needs. Recognition of the sick child and the deteriorating child in particular is obviously of the utmost importance and can be quite challenging in various circumstances. The following criteria contribute to successful recognition and response to these children. It requires a consistent approach to identify the unwell child. There are various paediatric early warning systems that are at our disposal that can help with this. Appropriate staff training and assessment, recognition and escalation is vital. It is very important that the primary care settings are able to stabilise and initiate the initial treatment and resuscitation of these sick children prior to any transfer. An assessment tool can help and is a key safety measure. It can be very challenging in certain settings when you're dealing with an acutely unwell child and the stresses and anxieties of the family. Now I'm going to share with you some tools that are available to help with the flow of this process. This is one of the early charts and scoring system that can be used to help assess how sick a child is. This is the one that's currently in use, but it is very shortly going to be replaced by an updated version. This is called SPOT. This is the System-Wide Paediatric Observation Tracking Tool. The principles are the same, but it hopefully will be easier to follow. The charts essentially break things down into age groups of patients and have early warning signs according to the physiology of the patient and their observations. This will hopefully help you recognise when a child is really acutely unwell. It will help you to understand and initiate the initial treatment pathways for resuscitation and provide a standardised method of referring patients so that the referring centre can understand the severity of the child's illness. The next tool that can be available to us is the safe transfer of paediatric patients. This is the STOP tool. This is quite helpful again in providing both the referring hospital and the receiving hospital with the acute information that is required. It not only provides existing demographic details of the patient, but again updates with the physiological and clinical basis of the patient at the time of transfer. An additional tool is the acute abdominal pain pathway series, and this is broken down into various different tables, and it's quite helpful because it's just a flow chart. So initially it's based on the patient's clinical signs and symptoms. It gives you a breakdown of medical red flags and surgical red flags and a combination of the two. So it will help you identify patients with sepsis from a medical perspective or acute surgical problems, including peritonitis and severe appendicitis, amongst others. It also gives you some key indicating factors regarding the age of the patient, as this will also help delineate your differential diagnosis as to the most likely acute surgical cause based on the patient's age and symptoms. There's also secondary tables, which again go into various potential causes of abdominal pain, appendicitis just being one of these. It also talks about mesenteric adenitis, Meckel's diverticulum, intussusception, and various renal pathologies, along with also medical causes of abdominal pain, such as sickle cell crisis. The third table in green brings into account the female gynecological pathologies which have to be considered in the postpubertal female. It is important that when we're using these tools in order to transfer and assess patients that we audit our processes. Examples of suggested audit tools are the regional transfers that have happened and following the STOP tool. Were they appropriate? Were they safe? Is there any improvements that can be made? The time to theatre, are the patients getting equitable access to theatre as required? Is that happening at the local hospital and also at the tertiary care centres? Is there a problem with access to emergency theatres, and how can this be improved? Also, along with appropriate incident reviews, case reviews, morbidity and mortality, and it's often a good idea to hold these on a regional and network level to benchmark your practice. So in conclusion, getting the child to the right place at the right time under the right speciality is absolutely crucial. It requires robust assessment, robust initial management and resuscitation of the patient to prevent deterioration. It's quite important that all of the centres that you're talking to have a streamlined process in which to transfer the patient. I hope that you find these tools and this webinar helpful in order to provide links and adjuncts to help with your patient care.
Hi there. My name is Jim Baird. I'm a paediatric consultant at Salisbury District General Hospital, and I'm hoping to talk to you about the paediatric abdominal pain pathway and appendicectomy, and the pathway component D, which is consistent involvement of the multidisciplinary team to care for children with abdominal pain. Why is this important? Well, it's important, I think, because children with abdominal symptoms can be presenting with either a mild viral illness in which they're relatively well, all the way through to acute critically ill patients who need an urgent multidisciplinary team approach. And we need pathways that ensure we can provide that care as effectively as we can. So what do we do in Salisbury? Well, we have a very simple pathway, which is in the multidisciplinary team shared care approach. This approach is for all children with abdominal pain and abdominal symptoms from 0 to 16, and is a pathway for primary care and for ED. The landing point for these children, referral point for these children, are to general paediatrics. And we'll then see them with an early middle grade paediatric review with referral to the surgical middle grade as required. Within the pathway, we have embedded use of safety tools such as sepsis trigger tools and pews. And we maintain clear escalation points for consultant involvement, as well as, if necessary, joint team decision making for transfer of the patients. Within setting up this pathway, there are some challenges. One of the key things I would recommend is to have really clear messaging about the simplicity of the pathway and also a single referral route, if that's possible. We were aided in this in Salisbury by having a single paediatric ward here in the hospital, which looks after both medical, paediatric and paediatric surgical patients. Also really important at the start of this journey, setting up the pathway, is really good primary care and ED liaison. We were helped particularly in Salisbury by excellent communication pathways between primary and secondary care, and some joint education events that were in existence between primary and secondary care, and that was really useful. You'll also need to make sure you have comprehensive rotas for both paediatrics and general surgery to enable a shared care approach, and clearly really good joint team working with your surgical colleagues is very important. One of the additional features that helped this was managing to have some shared care clinical case reviews between paediatrics, surgical colleagues, and our ICU and anaesthetic teams for our more critically ill abdominal pain patients, which proved really helpful for improving our joint working and our joint learning. It's important to manage induction and trainee handovers, particularly if the pathway for your hospital is slightly different from the pathways for other hospitals in the region, to avoid there being significant problems with the pathway at the time that the junior doctors move around. So in conclusion, I'd say there are a lot of different presentations for children with acute abdominal pain, and only a small proportion of these will require surgical intervention. Therefore, I would suggest that having general paediatrics embedded in your abdominal pain pathways is really crucial, and joint working with your surgical teams is a really helpful way of improving the pathway for children with abdominal pain. There's also a key safety element that exists within an MDT approach, which is that there is improved pathways of analgesia, there's improved recognition of very sick children, and improved treatment and management of those children. My final recommendation is that the pathway should be as simple and collaborative as possible, with audit opportunities for negative appendicectomy rates, as well as complex appendixes. And one of our new challenges is to try to embed the new GIRFT abdominal pathway within our existing pathway that we have already. Thank you for your time.
Hi, I'm Gareth Hosey. I'm a paediatric surgeon in Newcastle. We see a lot of children with abdominal pain, and a minority will have appendicitis. But it's important that we pick these children up as we treat it in a timely manner. Last year, as part of the GIRFT team, we developed a consensus document on the management of abdominal pain, and we're here today to discuss imaging as part of this pathway. And to discuss with us is Lee, the paediatric radiologist.
So Gareth, can you tell me the current investigative pathway for children with suspected appendicitis?
Well, as with any condition, the diagnosis is made as a result of careful history, examination, blood tests, but we found that an important component of the pathway is imaging. And so could you tell us the pathway that happens here?
Yeah, so we're very fortunate at the Great North Children's Hospital to have a 24/7, 365 availability of imaging around children. Also, we have a very collaborative working relationship with yourselves as paediatric surgeons, but also the acute physicians where these patients may present to. But really key to unlocking and delivering a service prior to GIRFT was making sure that we had the people that were delivering it had the skill set, and the skill set really out of hours or in hours is provided by people like myself, a consultant paediatric radiologist, consultant radiologists, paediatric sonographers and trainees. And key to that really was the development of a handbook around paediatric ultrasound, which was cascaded to all those who would potentially be scanning children either in or out of hours, with some handy tips about the best way to optimise imaging. And this was actually this was presented to the BSPR, so the British Society of Paediatric Radiologists, and actually it's been endorsed by them, so that's fantastic. The fantastic thing about making sure that people had the skill set to do this, meant that we were more sensitive and more specific, but importantly we were not doing CT of the abdomen in children with a radiation burden, and very, very rarely an MRI. So really we were really backing ourselves that we could provide an ultrasound service that would be imperative to having timely clinical assessment of a patient. So Gareth, having said that, do you think all patients with suspected appendicitis should be imaged as an emergency?
Certainly children who present in the middle of the night do not necessarily need to go to theatre in the middle of the night, and if there is any doubt we can arrange imaging in the morning, because it won't necessarily change our management. So we would either admit the children for observation as we would normally, or allow them to go home and come back for a planned scan in the morning.
In fact, it's not infrequent that following discussion with the surgeons or the acute team, that with relevant safety netting, that we may bring the patient back the next day for formal assessment during daylight hours for assessment of appendicitis.
So how do you fit these extra scans into your workload during the day?
So we don't have a great deal of wriggle room because we have an elective list which is normally timetabled or rotated to capacity. So what we did, we looked at how many patients we were scanning in the acute setting, whether that was from a ward, A&E, query appendicitis. We found that about a third of the patients that we had were actually non-elective patients. So what we've done is we've kind of adapted the way that we work. We've carved out a slot in the morning and a slot in the afternoon to ensure that we've got some capacity to scan these patients with appendicitis. But moreover, what we've also been fortunate to do is get some funding, which is going to really revolutionise the way that we do ultrasound here at GNCH. And that's in the means of another ultrasound room. And the plan for that would be have an elective room and what we call a hot room, and that will basically be all the acute ultrasound imaging that we need to do. And then a knock-on effect of that will be opportunity for training more registrars to help deliver the service out of hours here, so they've got a better chance of actually seeing appendicitis and kind of really getting a hands-on feel for what they're doing. So that's going to be a fantastic development that we have here at GNCH.
So I hope this has been useful. If you need any further information, then please contact us on the email below. I'll be very happy to help. Thanks.
Welcome to the Getting It Right First Time Paediatric Acute Abdominal Pain and Appendicectomy Best Practice Pathway Guidance webinar series.
Today we are going to be discussing pathway component 5F, monitoring and focus on time from clinical diagnosis of appendicitis to operation.
Each year, over 10,000 children undergo appendicectomy in England. The standard treatment for most cases of appendicitis is the surgical removal of the appendix. Fatalities are now thankfully rare in the UK due to access to surgery. Most cases of appendicitis are treated in non-specialist hospitals, although all specialist trusts with emergency departments will treat appendicitis. The sickest and youngest children are also treated by specialist hospitals. The rate of complex appendicitis in England has risen from 25 cases per 100,000 populations in 2013-14 to 31 cases per 100,000 population in 2017-18. This is concerning because a high rate of complex appendicitis has both a human and economic cost. In 2017-18, 3,400 children, that's 32% of all cases, were treated for complex appendicitis. Complex appendicitis is more painful and treatment more distressing for the child. Most children with complex appendicitis stay in hospital for 5 days or more, whereas most children with simple appendicitis stay less than 3 days. Furthermore, the complication and readmission rate is much higher. The cost of an admission with complex appendicitis is more than twice that of simple appendicitis, £5,829 versus £2,877.
In 2014, the British Association of Paediatric Surgeons and the Royal College of Surgeons issued commissioning guidance stating that more than 90% of appendicectomies should be performed within 12 hours of decision to operate. There is strong evidence that better outcomes are observed in children who have inpatient waits of less than 24 hours until surgical intervention, and some evidence which suggests that operating within 12 hours may confer a benefit. Although the evidence base is unclear, there was clear consensus amongst the group of experts involved in the development of this pathway that appendicectomy should be performed within 24 hours of listing. As a key indicator of service performance, this metric should be closely monitored by trusts to assess the responsiveness of their service. This is an important issue related to quality of care of child's experience as well as efficiency. Alderhay Children's Hospital developed their own emergency listing information system called eList to book and manage children needing this surgery.
Challenges. There was an over-reliance on one member of the development team who had developed the code to support the system and then left the trust. This created some challenges with regard to system updates and improvements. Additional work has been conducted to ensure enough developers understand the system to provide adequate support. Although it was easy enough to introduce the system, as people wanted a more automated process, a concerted effort was made to ensure people were putting the correct information into the system. As well as providing demonstrations and training for the first few weeks, clinicians were still required to come to the theatre to make bookings, albeit via the system. Once confidence had improved, requests could be made from anywhere in the hospital. Maintaining communication between clinicians and anaesthetists was a challenge as they no longer crossed paths during the booking process, so phones were implemented.
In Alderhay Children's Hospital, monthly audits are carried out of team performance against treatment time targets for 24-hour diagnosis to surgery and also fasting monitoring.
A national tool is not needed. Trusts can develop their own tool using locally recorded data and monitor through this, as Alderhay have done with Ellis. As Alderhay have demonstrated that this is a valuable tool, we need to ensure similar tools are used in all trusts to enable national data sharing and comparison to improve patient journeys and outcomes and enable benchmarking to support best practice through model hospital.
Thank you for listening. For more best practice pathway guidance, visit the website on screen.
Hello, I am David McAfee, a Consultant General Surgeon at South Tees Hospital in the North East of England. The GIRFT report highlighted variation between surgeons with regards to antibiotic use in paediatric appendicitis. Some local variation will be justified based on local microbiology audits. Our hospital has a 25% E. coli resistance rate to coamoxiclav, for example. However, we do need a more consistent national approach to prescribing in terms of type, route, and duration. This consistently will help all, the child, their parents in planning school and work, your surgical and paediatric teams, play staff who reinforce ward-round information, ward staff in terms of discharge planning, our roles as antibiotic stewards to protect the precious antibiotics we currently have. There will remain areas of contention and need for discussion within your teams and the wider national network. This 5-minute talk will give pre, intra, and post-operative suggestions to aid adoption of consistent, appropriate antibiotic strategies for paediatric appendicitis. It is a recorded webinar, so whilst I may skip through tabulated slides quickly, you can always return to scrutinise them at your leisure. Firstly, an opportunity to reinforce the pre-optimization of an unwell child. Following your clinical diagnosis of appendicitis, deliver intravenous antibiotics by local protocol at the earliest opportunity, in addition to adequate pain relief and maintenance intravenous fluids. In our hospital and many around the country, children are allowed to sip water or clear cordial juices till theatre. This ensures comfort and a degree of hydration. There can be disparity between elective and emergency practice, but we imagine sip to send becoming standard practice once we get sufficient data to reassure all that it is anaesthetically safe. If you have a septic child, identify this early, institute sepsis 6, and consider giving a bolus of fluid 10 mL per kg, then assess the response to the bolus and the intravenous antibiotics. There are a wide range of antibiotic protocols worldwide. This one is from the Paediatric Antimicrobial Stewardship Group from August 2021. Contrast this with the current local protocols in 6 leading tertiary paediatric centres in the UK who kindly shared their current protocols with us. So how can we safely reduce variation? One is samples and local audit. The next slide will show that most operations now are done laparoscopically. So can we go to the next slide? Thanks. Basically, in theatre at the brief, I highlight the importance of taking samples. If there is no pus or fluid in, once the appendix is retrieved in the retrieval bag, you can run a swab, a normal bacterial swab, over the surface of the removed appendix. These two ways would be ways of gaining samples and then sending to the lab. Other ways to reduce variation: inter-unit and operational delivery network collaboration in terms of protocols for antibiotics, national guidelines, and here I would like to particularly thank Liz Whitaker at Imperial and Paddy McMaster at North Manchester General for guiding me with regard aspects to this talk, and importantly providing counter arguments to some of my suggested points of view, and part of it explains the ongoing variation that we find nationwide. Ultimately, ongoing GIRFT national reviews, which prompted these webinars, are important. In terms of postoperative antibiotics, naturally our aims are to clear any residual systemic infection and reduce the chance of postoperative infectious complications, whether that be superficial wound infection or deep infection in the abdomen or pelvis. No one wishes a child to come to harm, but we hope the data presented by GIRFT will provide a consistent guide and reduce unnecessary antibiotic use. 3 examples. There really is no need for further postoperative antibiotics if simple appendicitis is found and treated surgically. If you do send samples, chase the culture results and link these findings with the clinical progress and discuss with local microbiology about the antibiotic regime. If the child is tolerating diets and fluids, then the oral route becomes an option in less complicated cases. Here there is a counter argument to taking samples, however. There is evidence to suggest they prolong or broaden the course of antibiotics, including antifungals. So most guidelines don't seem to recommend antibiotic guidance tailored on these cultured results at surgery. Where there are complications such as sepsis or abscess formation, then cultures are definitely indicated to identify the single specific organism responsible, but not the multiple flora from the gut which are suctioned or washed out in theatre. Ultimately, a child with a normal immune system will do a lot of the clearance of infection themselves. We need to be mindful that if specimens are collected, it could be hard to persuade clinicians not to recommend treatment lengthening or broadening or change. So this is where local consideration and discussion is required. Another area of discussion would be with your consultant surgeons in their views on what complicated appendicitis means to each of them. Does a local abscess in the right iliac fossa or pelvic area suctioned out and irrigated in a non-systemically septic child count as complicated? A majority may sway towards, as long as the abscess is cleared, then extended antibiotics are not required. But would you give any postoperative doses? A septic child with a large abscess in, say, one quadrant is a little easier to justify 3 days of intravenous and 2 days of oral if their gut function returns and they look well from the end of the bed. Perhaps once a year, an unfortunate child will present to your hospital with 4-quadrant purulent peritonitis secondary to perforated appendicitis. Prolonged antibiotics and antifungals are reasonable in these cases and should be discussed with microbiology or paediatric infectious diseases, as they may also in the future wish to exclude a primary immunodeficiency if they run an unusual course. For such children, short courses of intravenous antibiotics is unwise. They need longer treatment. And in addition, consider getting a long line at the end of this surgical procedure placed by the anaesthetist for the delivery of longer courses of intravenous antibiotics. And finally, as a product of this talk, your team may decide to undertake fewer blood tests. Even waiting until 72 hours for a blood test seems to be entirely reasonable now in complicated appendicitis cases, as long as they're making progress. The debate will still rage as to whether that should be a full blood count, CRP, or even procalcitonin. Procalcitonin is the most expensive, £14 compared to £1 or £2 for CRP, but yes, it's got a sensitivity of 63% and a specificity for bacterial infection of 89%. So those are discussions that you would have locally or regionally. So in summary, we need to ensure consistent antibiotic policy. Ideally, that could be regional or national. Use regular audit to see when you first deliver these antibiotics, what do you use, what's your duration, and if you've taken samples, what did you grow? And do adhere to antibiotic stewardship guidelines and consider, can we reduce the number of blood tests undertaken for children? Thanks very much.
When a patient and their family are admitted to hospital with abdominal pain, querying an appendicitis, it is important that they understand what appendicitis is, the investigations the child may need, and the possible treatment options.
This can be a really worrying time for patients and their families. It may also be their first trip to hospital and anxiety may be high. They may be upset at the thought that they or their child may need an operation.
Feedback from previous families on their abdominal pain pathway said they felt it hard to take in their child needed an operation, and the consent process felt like a blur. They also said they didn't feel like they were being kept up to date with their child's plan of care.
It is important that children and families receive information about investigation and their plan of care in a way that they understand. This may be taking into consideration a child's age and the language they speak at home. If parents are making decisions surrounding their child's care, for example, in the consent of an operation, they should have the operation explained in a language they understand and information surrounding this in an appropriate format so they are fully informed. It is important to take into consideration the child's development and if there are any factors surrounding this that may affect their understanding, such as learning disabilities, visual or hearing impairment, or any other issues.
There is a team of play therapists who work in the accident and emergency department and on the children's ward. A play therapist works with children to relieve anxiety that they may be feeling coming into hospital. Can be a worrying time. Play therapists will also use play therapy to calm and distract children during medical interventions.
Play therapy can involve talking about interventions or investigations that the child may need. We can then stay while the intervention takes place to distract the child by playing with toys, reading and making music, and any other techniques that we feel will benefit the child.
If a child has been referred to accident and emergency with a possible appendicitis, then they may require a urine test, a blood test, and an ultrasound scan. It is important to talk to children and families to explain the investigations and the reason why we need to do these interventions.
Following these investigations, the surgeon will make a plan of care which may require admission to our children's ward. It's important that children and families are also kept up to date with the plan of care.
If a child needs to go to theatre to have their appendix removed, they will require a general anaesthetic. Play therapy can reduce anxiety surrounding this, including what happens in the anaesthetic room and how they fall asleep. The play specialist can accompany children to theatre to distract them whilst they have a cannula inserted for IV anaesthesia or a mask to have inhaled anaesthesia to anaesthetise them for their operation.
It is important that patients and families are aware of the plan of care so that they can follow the pre-operative fasting guidelines and have appropriate expectations about their care pathway to theatre. Appendicectomy patients are usually booked on an emergency list, which comes with the added complexity that there may be delays if another emergency comes into the hospital that has to take priority. It is important that the child and family have time to process the plan of care so that they can ask additional questions if they need to.
Following the child's operation, they will need to stay in hospital until they are fully recovered and ready to go home. The family needs to be aware that post-op plans of care will be made once there has been an accurate assessment of the appendix and the abdomen.
If the operation is more complicated, such as a perforation of the appendix was discovered in theatre, this will mean that the child will need prolonged IV antibiotics to treat the infection appropriately, which will delay any expected discharge.
It is important that the child rests, has adequate pain relief and nutrition. When the child is discharged home, families must have appropriate guidance on ongoing antibiotic treatment, pain relief and advice, who to contact if they have any concerns, and an agreed time to refrain from sporting activities to enable the surgery site to heal.